over, and obviously we're using less rooms because of the coronavirus. So I apologize to anybody out there for the late start. At this time, if we're going to have the call to order, and then if we could do the roll call, Hillary.
So when I call your name, if you will just indicate whether you're attending remotely and then where from, whether it's Frankfurt or your home district or your office. So Senator Parrott. Representative Bojanowski.
Yes, I'm present virtually from District 32.
Thank you. David Allgood. Leanne Creech.
Yes, I'm participating remotely.
Thomas Loreno.
Well, I'm participating remotely.
Lisa Lee. Wendy Morris. Brad Schneider. Steve Shannon. Amy Stade.
I'm here and I'm participating remotely.
Brenda Wiley. Bonnie Thorson Young. Senator Julie Rocky Adams.
I'm on remotely.
And Representative Riley.
Here in the room.
Wonderful. Thank you.
At this time, if we could have a motion for the approval of minutes from the last meeting. We have a motion and a second. All in favor say aye. Minutes approved. We are going to, we have a new member this week. It's Commissioner Wendy Morrison, and she is going to be one of the presenters in our second presentation. At that time, we'll allow her to introduce herself and tell a little bit about herself during that time frame. So on our order of events, we're going to flip the two presentations. And at this time, we're going to have the Department for Medicaid Services, an analysis of the supports for community living waiver and exceptional support waiver services. And we're going to have Commissioner Lee and Policy Advisor Hoffman at this time. And if they could, go ahead and start with their presentation.
This is Leslie Hoffman. I don't think Lisa's on yet.
Okay, we'll just try to see if we can contact Lisa and get her on. Okay, we're still waiting for both members from the cabinet, so we'll just have a little delay here.
I received a text message from Commissioner Lee, and she said we're trying to connect.
Okay, that sounds great. We'll just wait for her at this time.
I think she meant Wendy as well. Thank you.
Technology's great, but it does have its glitches. Commissioner Lee, are you with us now? Ms. Hoffman, do you have part of this that you can go ahead and present, and then we'll get back to Commissioner Lee when she gets online?
Yes, I can start when she gets online. I'll just let her take it over.
Oh, okay, that sounds great, thanks.
And do I just tell you when I want to advance? Is that how we're doing this one?
Yes.
Okay. Okay, so this is DMS's presentation regarding exceptional support waiver service task force. Go ahead and advance. So home and community-based waivers are designed to give individuals alternatives with disabilities, alternatives to institutional level of care. They should complement other state services that might be available, state plan services, other program services, public programs. Sorry, I'm receiving feedback. Family and community sports to meet the individual's needs. The waiver services should allow an individual to live safely in the community, and if the individual needs exceed what safely provided in the community, he or she may not be appropriate for the waiver services. And that's one of the things that we're also held accountable for through CMS, is to ensure that we will provide health, welfare, and safety in the community, the same level that they would have received in a facility. Advance, please. Move my screen. Sorry, I'm moving my screen. Okay, so for us to receive the federal match from CMS and for an approval of a 1915C waiver, we must provide the same level of care that they would have received in the facility. We must demonstrate cost of care in the community at equal to or less than the institutional cost, and that's budget neutrality. You may have heard that before. We are held accountable to conduct monitoring to ensure waivers meet the quality standards that we've told CMS, as well as ensuring safety of the member. Advance, please. And this is just a list of all the waivers that we have. We have the acquired brain injury and the acquired brain injury long-term care waivers, and that's for individuals that are 18 years or older. We also have the HCBS waiver for individuals age 65 and older, or individuals of any age with a disability. We have the model waiver 2 for individuals, which is dependent on a ventilator more than 12 hours a day. Physician monitored weaning program, and that's pretty much nursing services for those individuals. We also have the Michelle P. waiver, as well as the SCO waiver for individuals with intellectual or developmental disabilities. Advance, please. So waiver budgets are determined by evaluating expenditures from the previous year, and we determine based on utilization. Budgets must be cost neutral per CMS, and that's the budget neutrality that I spoke about before. And to be cost neutral, the average participant expenditures must not exceed the average per person cost of furnishing institutional services for an individual with the same level of care. And I will mention here that they do hold us accountable to include the costs that would be outside of the waiver for the holistic cost of the member. So we do include costs that may have incurred at a hospital, doctor's office, anything that would be outside of the waiver services. Advance, please. We listed here the waiver populations that we currently have, the populations served, and this is calendar year 2019. We used calendar year 2019 because we felt like it would be the most accurate. When we go back and pull claims and data, oftentimes providers bill at different times. So we wanted to make sure that we could get the most accurate timing for the claims that would have been submitted over a period of the calendar year 2019. So we included here the total paid claims. And I think Representative Riley asked about the federal share as well as the state share, and we've got that information on there, and as well as the totals. You can see the CMS provides about 70% of the waiver services and funding, so we wouldn't want to lose the approval of CMS at any point. Not meeting one requirement in one waiver or having deficiencies in one waiver put all their waivers at risk with the state. Advance, please. This is the waiting list that we currently have. ABI LTC, ACB, Model Waiver 2, Michelle P. and SCL. And we included the waiver year, and if I could explain that just a bit, the waiver year is not a calendar year and it's not a fiscal year. It is the year in which CMS approved the waiver. So depending on when we submitted and had the waiver approved is when the waiver year starts. Waivers run 5 years. So each one has its own specific waiver year, I'm sorry. The waiting list, I did want to mention the ABI long-term care. We're working starting today to allocate slots because that waiver year just started, as you can see, 7/20. And so we should be able to allocate those slots out and have a zero waiting list hopefully soon. So it will take some time for folks to get the information in and I'll also explain, because sometimes people have questions about the funded slots versus the active slots. So, for example, in the acquired brain injury waiver, the funded slots are 383, and you'll see that there are 281 active. Let me see if I can find another one. Let's see when it's clear. So let's look at ABI long-term care. Funded slots are 438, and the active slots are 390 with a waiting list of 38. So that brings questions. And anytime a member utilizes a service, one service, for at least a 50-minute increment, even say that they left the program or they unfortunately passed away, or maybe moved to another state and they're on Indiana or Ohio Medicaid or another state, those slots cannot be utilized by anybody else. CMS holds us accountable per the waiver to be unduplicated. Advance, please. We included the definitions for the SCL waiting list categories, which is emergency, urgent, and future planning. Emergency, I think of as immediate services needed now, and urgent is individual services within 1 year, and future planning is individual services needed with 1 year and is not currently receiving other services, not receiving services and does not currently need services in the custody of DCBS. So we just added those in for knowledge of the public today. Advance, please. And that's our current numbers when you break it out into categories. Okay, and we were going to explain just a little bit about Kentucky's 1915C SCL operations. So you have the SCL waiver, And DMS is the authority over the waiver itself, so we're held accountable, monitoring and quality assurance, and we maintain CMS approval of the SCL waiver, program reviews, and create and revise policy. And then Dale provides participants activities related to participant-directed services, or what we call PDS. And then we have DBACID that oversees exceptional support approval, waiting list management, review of incident reports, and follow-up, provider monitoring, including certification, training, and technical assistance. Advance, please. Let's see, this is exceptional supports by number. Residential, 163, consultative and clinical therapeutic services, 82, respite, 6, so that's a total of 251. And again, that was on a calendar year for 2019. And we also included the paid claims. In calendar year 2019, we only had one individual denied, and that was for lack of information. Advance, please. We had some recommendations by CAP and CARP, and one was to extend the prior authorizations to 12 months. And I believe the team was in agreement with that. For non-clinical services, we wanted to make sure that on the non-clinical service side that we had a lesser time period due to scope of work, and licensure would hold clinical providers to evaluate those services more often and to find the current need. Using a single assessment tool, DMS is currently evaluating the use of validated universal assessment tools. CMS requires us to make sure that we have validation and make sure that it has validity and reliability. I always remember those two. And not every tool, even though they appear to be wonderful, have the validity and reliability that CMS is looking for. But we're always open to suggestions if anybody wants to send anything in. This one would require a regulation change and a waiver amendment. Establish a higher level of care while retaining the exceptional support system. In addition to waiver services, individuals should be, as I mentioned before, receiving Medicaid state plan services, or maybe other services, natural supports. Unfortunately, if the care goes beyond what we consider nursing facility waiver approval, then they might not be appropriate for waiver services. And I know that's not always what folks want to hear, but we have to maintain that these individuals are appropriate and safe in the community. This would also require a regulation change as well as an amendment change. Advance, please. Revising the exceptional support rate methodology. CMS requires that states have a documented evidence-based rate methodology. Kentucky is working on an established evidence-based methodology to support provider reimbursement levels. And this would also require a regulation or an amendment to the waiver. Increase the number of units allowed for clinical and therapeutic services. Kentucky will evaluate the possibility. However, it is critical, it is critical in any increase. We have to make sure that there's no duplication of service under the state plan, because that is not allowed with CMS. You can't be duplicative in your state plan as well as in your waiver. To establish an exceptional support rate for case managers, the SCL case managers did receive the SCL case managers did receive a 10% increase in their reimbursement rate in 2018. CMS requires again that states have a documented evidence-based rate methodology, and that's something that we're working on. Advance, please. Oh, and let's work together, and, I am always open to listen to anything you have. Our team there at Medicaid is always willing to listen to any opportunities, suggestions, that you may come up with. So, do I have questions?
Yes, we have a few questions. First of all,
Okay.
Amy Stade has the first question.
Hi, thank you so much, everyone. Ms. Hoffman, hi, nice to meet you virtually. My first question is about the cost neutrality that you brought up. Would you agree that when you break those numbers down, the cost per person of the SCL waiver per day is about $215 a day? I just divided your numbers by the total participants, divided that by $315 a day and divided that by 365 days, got to $215 a day. That's your average cost participant in the SCL waiver. Now, when you contrast that with ICF level of care, granted, all of the state-run ICFs have slightly different rates, but they're all around $1,200 a day. So, would you agree that Kentucky is really falling well within that cost neutrality requirement?
So our cost neutrality changes on a regular basis, and if things haven't changed, we submit an annual and an 18-month lag report based on cost neutrality, so it can change. It also changes based on, like what I said before, utilization or medical costs. We have to add those in. So, for example, if a member went to the hospital and, had heart surgery, or I'm just giving that as an example, we do have to take those costs into consideration. And the budget neutrality is actually based on the aggregate of the clients that are compared to the same amount of days of stay. I know this is confusing, but days of stay in an ICF IID. So it's not as easy for me just to tell you that, yeah, that's correct or that's not correct. It's definitely a formula.
Sure, but would you agree that the community-based care provided in the SBA waiver is much more cost-effective than the $1,200 a day per diem for the ICF?
It's more
It's broken down at about $215.
So it depends on what services the client is receiving. If the client was receiving a full array of services, then for example, residential's expensive over a period of time, case management, that's a every month required service, those kind of things. I can't tell you right offhand of what you're saying is correct. It's definitely a better quality of life to be out in the community if we can meet their needs. But again, CMS holds us accountable for us to take care of them and provide their safety with the same level that would have been in the institutional type setting.
Sure, it's just, when you do the math that you provide, it's about $215 a day versus that $1,200. Yeah, and I just wanted to put that out. Thank you.
Thank you. Thomas Lorino.
I think I'm unmuted. Am I unmuted?
No, we can hear you now.
Can hear
You
you.
can hear me? Okay, great. Thank you for joining us, Ms. Hoffman. Again, it's nice to see your face to the name. I'm curious about something, and it really ties in with what Amy was just saying. Throughout was what? Am I getting too much feedback?
Yeah, I did hear you. I'm sorry.
I'm curious. I was curious as to what number you were using, for this neutrality, for the ICFs. And she mentioned something like $1,200. Are you comfortable with that number? Is that a fairly accurate number for what it costs to institutionalize, these individuals?
I haven't recently looked at the cost neutrality for an ICF IID, an Oakwood type of facility, so I can't answer your questions. I can go take that back with me, but I don't have anything specific with me today.
So you're not sure if 1,200 would be a fairly accurate number or even a close number?
I would have to look, I've just
Because
returned back to the cabinet.
I guess the only reason why I say it is because I have to agree with Amy that I can't see how any of these programs could even approach that per day. No matter how many services that client gets. I mean, we recognize that they're in residential services, they can't get other services except for ADTs and a few other little odds and ends like behavior supports and whatever. And that's probably gonna be your most expensive client. So you're not even coming close to the $1,200.
If everyone cost $1,200 a day, we would not meet budget neutrality for CMS, and the waiver would not be viable, and
Right,
we
but you
wouldn't
can't
have
even,
to match.
but you can't even come close to the $1,200. No matter how many states they're receiving, whether it's SCL, Michelle P, ABI, or any other. I mean, you mentioned something about them having heart surgery or something, but they're gonna have an additional expense even if they're in an ICF. So that isn't gonna change anything.
Correct.
So, I mean, what are we talking about here? Are we, I mean, does budget neutrality kind of mean nothing?
So the budget neutrality says that we will spend equal to or less than what they would have in a nursing facility or an ICF ID.
Yeah, I guess my question is very simple. Have you ever had a client denied because they couldn't meet budget neutrality?
I'm not going to speak to that. There used to be a clause in the waiver, in the regulations, but I don't want to speak to that because I don't know if it's still there anymore. So, again, I could follow up on that.
I'm just curious, has any client ever gone over the cost of what an ICF, any waiver client ever gone over the amount that an ICF would have cost them?
Ms. Hoffman, if you could get us that information before the next meeting, I think that would help us get that answered. Thank you.
So
Thank
let
you.
me make sure I had it right. So you want to know if any client, can you give me a time period, has ever exceeded?
The cost of an ICF. Because I find it almost incredible to think that anybody could. But of course, I don't know what the amount of an ICF would be. And you're not sure of that number at this time.
Hello, this is Commissioner Lee. If I could speak, please. I understand what you're saying. You want to look into the budget neutrality piece. As Ms. Hoffman stated, the costs on the slide were strictly for the waiver programs themselves. It did not include any medications or pharmacy, physician office visits, those sorts of things. So in order to look at the budget neutrality piece and see if any individual has ever gone over the ICF, we would definitely have to go back and look at this on an individual basis, which we are more than happy to do, to get some of those numbers for you. Of course, we can't identify any particular individuals, but it will be very, a little bit detailed in getting all of that information to include not only the waiver services, but their medical and pharmaceutical services as well, to get that information for you. We'd be more than happy to take this back and come back and either provide you with an answer through this committee or bring it back to the next meeting that we have, regular scheduled meeting that we have, to give you a little bit more information on the costs related to delivering these services to waiver participants.
Commissioner Lee, while I'm still got your attention, I mean, I'm curious. I mean, we have to compare apples and apples, not apples and oranges. Now, if they're receiving pharmaceutical services and additional things, is that not also included to their course in their ICF? I'm just curious, in the relationship between their waiver services alone versus what it would cost the state of Kentucky to have them in an ICF. Not,
Yes,
because their pharmaceuticals are still going to get added on both sides.
understand your question, and we'll go back and make sure that we understand what the ICF all-inclusive rate includes, so that we can compare apples to apples as much as we can. But I understand your question, I understand the information that you want to look at, and I'm more than happy to go back and look at that and bring it back to you.
I would just like to see, just how much the state of Kentucky saves by having people in the waiver programs. Because I think that's important.
We think that's important also, and we will get that information and bring it back to you.
I mean, beyond the other things that they gain by being in the community, which you can't put a price on. I mean, that is invaluable.
Commissioner
That should
Lee,
also be considered.
Commissioner Lee,
very
thank you
much.
for the answer, and thanks for coming on board, and I hope that the question got answered. If not, let's get that for the next meeting. If we could, Senator Parrott has a question.
Thank you, Mr. Chairman. My comments are, I have a question on page 5 of the handout, where it says budgets must be cost neutral per CMS. To be cost neutral, the average per participant expenditure must not exceed the average per person cost of furnishing institutional services for an individual with the same level of care. My question is, what are those numbers?
I don't have those with me.
Okay.
One thing that you need to remember, though, is that it's based on an aggregate for the waiver. So we have to take a waiver in a whole, and we report budget neutrality for that waiver. It's not like, what's an aggregate? So it's all those folks that are in the program, and it's also, it's also based on days of stay. So we have to look at that as well. And they only compare the individuals to the individuals in the ICFIID or nursing facility that have the same amount of days. So duration, medical cost, service cost, and utilization.
Okay, but you kind of answered my question, but you didn't. I'm asking for what that number is, what that average per participant expenditure must not exceed the average per person cost of furnishing, whether it's institutional services or with the individual with the same level of care. That's what I'm asking. Am I missing something?
I understand. I don't have the numbers for the budget neutrality with me today. I'm sorry.
Okay.
Representative, Ms. Hoffman, if you could you get this information to us by next meeting, and also the information Ms. Loreno asked for earlier? If we could have that data, it would help us a great deal.
One more question.
Senator Parrott has one more question.
And I'm new to this, so I heard a figure of $215 per day. What was that attached to? Or what should that
Senator Parrott, this is Amy Stade. I'm the executive director at CAP. I quickly did that calculation. If you look on her slide where she puts, where she breaks down the federal share, she has how many participants are in the SBI waiver. I divided the total cost by the number of participants and then divided that by 365 to get an average per day per person, and that's $215.
Okay. They just did the division for me, and I see it now, so thank you.
You're welcome.
And now we have Representative Bojanowski has a question.
Okay, so mine's a more basic question than that. Let me get back to the page I was on. All right, so, I'm sorry. Okay, here it is. On page 12 of the flyer, under establish a higher level of care, it says those with a level of care beyond what the waiver can safely provide may not be appropriate for waiver services. And do I understand that means that they would then have a recommendation to stay with them? Or what would happen to someone who is not appropriate for waiver services?
So waiver services in combination with other services should be able to support the client out in the community. One of the problems we run into is that CMS expects us to be able to care for that client and at the same level of care. The level of care is nursing facility level of care, so there is no higher level of care as far as CMS is concerned. It's nursing facility level of care.
Okay.
So oftentimes in nursing homes, you will have other supports that are similar or alike to waiver services, but maybe not exactly. If somebody needed, nursing, I'm just saying this as an example, 14 hours a day or something like that, that's not something that's covered under the waiver. Does that make sense?
Yes, and then could you just state, what does ICF and IID stand for?
Intermediate care facilities for individuals with intellectual disabilities. And that's like an Oakwood facility.
Okay. Thank you.
Yes, ma'am.
Thank you, Representative Wojciechowski. And I don't think we have any more questions. Ms. Hoffman and Commissioner Lee, thank you for the report. If you could get us that data that was asked for earlier before the next meeting, we would appreciate it so much.
Okay, thank you.
Thank you. Y'all have a great day.
Thank you so much for having us.
Now, at this time, we will have Commissioner Morris and Division Director Johnson, and they will be talking about development of intellectual disabilities, analysis of supports for community living waiver, and emotional and exceptional support waiver services. Are both of you online?
Yes, sir, this is Commissioner Morris.
And this is Claudia Johnson.
Thank you both. Commissioner Morris, if you could, you're a new member, if you could introduce yourself quickly before you go ahead and give the report. Thank you.
Sure. I'm Commissioner Wendy Morris here with the Department for Behavioral Health, Developmental, and Intellectual Disabilities of the County for Health and Family Services. And Claudia is the Division Director for our Division of Developmental and Intellectual Disabilities.
Thank you so much. And if you guys are ready, go ahead.
So you can go ahead to the next slide, please. I just have a few slides just to talk about exceptional supports. The Department for Behavioral Health and we administer the supported community living or SEL waiver through a contract with the Department of Medicaid Services. So even though we're both in the same cabinet, we do have a contractual agreement. The SEL waiver includes a specialized rate for people who have exceptional medical or behavioral needs. And this applies to both the traditional and participant-directed services. You can go to the next slide. So these supports are for the sole purpose of ensuring health, safety, and welfare of the waiver participant. They're based on the cost of providing the service, and it can't exceed 2 times the upper limit payment of the service. It's authorized to be reimbursed in one of 2 ways, either a higher rate from the upper limit for that service, or they can get additional units in excess of a service unit, but it has to be one or the other. It cannot be both. Advance, please. So here's just some examples of some services that are eligible for exceptional rate supports. One, this residential level 1, that would be the staffed residence, like a 3-person home. Level 2, your family home provider, where there's 12 hours or more supervision needed. Community access, this might be allowing a person to join a club, become active in their church, join the choir, that sort of thing. And then that service would back off as a person gains natural supports in the community. Personal assistant, respite services, so the caregiver can have a break. And that's only if a person lives alone or with family. Day training is also eligible as long as it's not provided by an adult day health care, which is a licensed facility that follows a medical model. Some services that are available or eligible for exceptional support units, so additional units, would be consultative, clinical, and therapeutic services, person-centered coaching, personal assistant, and again, respite. Advance, please. So there is a packet of information that's needed in order for us to evaluate the request. And that's in the MWMA system. It's a Medicaid waiver management application, so it's done online. What's needed is the name and some basic identifying information, a description of the supports that are being requested, some details about the challenges that are presented by the recipient is encountering and the interventions that need to be provided. Some summary notes about a person-centered team meeting. There's a group of folks that need to get together, case manager, service providers, the person, their guardian, get together and talk about these things, and everybody is in agreement that this is needed before the packet is submitted. This updated service plan would need to be put into the MWMA system. And then if there's an ongoing request, there'd be a description of any interventions that had been taken and what the results were, and then a detailed cost analysis. And there is a rate determination template that all requests need to use when they're asking for a cost increase. Next slide, please. So again, for the process, all requests have to be made with the consensus of the person-centered team, which I just talked about. And that's all outlined. The process is outlined in a provider letter that came out 3 years ago. And other than emergency situations, the services are not to be started until they're approved. If it is an emergency, there's a process to review that retroactively. Within 1 business day of that team meeting, the case manager can submit the packet to our department via MWMA, and we have 3 business days to process that request. We may need to ask for additional information from the case manager, and that's referred to as an LOI or lack of information. I can tell you that happens in about 39% of the cases. Maybe a little simple question, it may be a series of questions. Some case managers will turn that answer around really quickly. Others never respond to our questions. The providers, case managers have no required turnaround time. Again, we have 3 days, but the rate doesn't require any turnaround. It's what I will tell you for fiscal year 20, we only denied 4 requests. There were times when people didn't answer the questions or get back to us, but we only had 4 formal denials. And then if it's approved, that authorization lasts 6 months, and then continuation can be requested. Next slide, please. So we wanted to respond also to some of the stakeholder recommendations. Again, this waiver program is a Medicaid program, and the Department of Medicaid Services set the policies in accordance with 907KR 12010 and 12020. But 2 of the recommendations that were made actually don't require a regulation change, and we are in agreement with DMS that these changes could be made. One is to extend the prior authorization of non-clinical exceptional supports to a year. We agree that that is doable. And the second is to backdate approvals to the date of the initial submission if all the required information is included and all the LOIs were answered, that lack of information. So it may take a series of days or weeks to do all that back and forth, but those could be backdated to the original submission. And that concludes my slides, but we can take questions.
Thank you, Commissioner Morrison. We'll, Mr. Lorino has a question.
Am I unmuted?
Yeah, go ahead.
Can you hear me?
Yes, sir, we can hear you. Go ahead.
I can hear you, yes.
Good. It's a real simple question, and it's one that I've heard a lot about. What's the rationale for the 1-day turnaround by the case managers? I mean, if I've heard one thing, I've heard case managers complain, and this kind of harps on something that Steve Shannon talked about at the last meeting. Because of the difficulty the case managers have about getting this thing done in 1 business day, a lot of them just kind of lump it. They don't do it. And a lot of individuals that need these supports don't get them because their case managers, they're busy. But what's the rationale for the 1-day turnaround? Well, I don't understand it.
Claudia, are you able to address that, please?
Yes, I can try to answer that. So when the process was put into place, I believe the rationale was that if someone requires exceptional supports, it's because of a health, safety, welfare issue. Either the person is very medically complex or having behavioral issues. And so once the team meets, the team members that have the information, either the behavior specialist or whichever team member based on the request, should have that information ready to go, and the case manager would upload that the next day so that there would not be a delay in getting those services that are needed.
But is one day necessary?
Well, that's what's in the protocol right now. It's something that if Medicaid's willing to talk about, we could discuss.
yeah,
But that's what the protocol is.
You know, like I say, this kind of goes in hand with something that Steve Shannon talked about at the last meeting, that case managers, I'm not gonna accuse them of not doing their job, but a lot of them sometimes are just so busy that they can't meet that one-day turnaround. I think it's something that maybe you might want to, take a look at. Thank you very much.
Thank you.
Thank you, Mr. Lorino. Any other questions from anybody?
I have a
Virtually?
question.
Yes.
Amy spoke. Hi, Commissioner Morris or Claudia, I have, whichever one is better equipped to answer this questions, I have two questions. The first question is about the testimony that we've heard regarding reg changes to implement some of these proposals, which I totally understand. I know a lot of stuff has to go through the reg process. But I wanted to point out and ask a question is that currently, if you look at the payment reg for the exceptional supports protocol, the exceptional supports protocol is incorporated by reference in that reg. The version of that protocol that is incorporated by reference is the 2016 version, which is not what we're currently operating under. As you all both know, the cabinet has the ability to issue provider letters which supersede regulation. So would it not be true that the cabinet can issue some provider letters to implement some of these changes without having to necessarily go through the complete regulatory process?
And Amy, this is Claudia, and that's why we said that it would not require a reg change to do extend the non-clinical to a year or to backdate, because those are not regulatory changes. Those were put in place with the provider letter. So Medicaid, but the other is a Medicaid question about what they can and can't change without a reg.
Sure, and but also the payment mechanism, or excuse me, the rate methodology to determine how much someone is paid via exceptional supports was also included that provider letter. So presumably that adjustments could be made to that without having to open up the reg. Correct?
That's a Medicaid question.
Okay. My next question is about the level of care discussions. So I think that what's really kind of getting lost in this level of care terminology, and that could be my fault for using the incorrect term, but I think that what happens often is that providers will accept a referral of either an individual who's coming out of an ICF or or from another provider who has a very complex set of support needs, and the exceptional supports protocol will be requested and all of that. But then the provider realizes that the individual's needs are far too great to be served either in the waiver or maybe just by that particular provider. And the problem with the current system, which is why we included that sort of next level of care / referral practices, is that a provider, when they acknowledge and admit that they don't have the ability to support a participant, no real mechanism to refer that participant out, it's often difficult to get another provider to accept the referral. What further complicates this is that it's often difficult to get some of these individuals with co-occurring mental health conditions into an ICF because their IQ exceeds that which is appropriate for ICF level of care. And I think that's where we were coming from with that sort of recommendation. And my question to you would be, what sort of processes can we put in place, or what changes can be made to help alleviate this problem so that providers aren't caring for people that they admit that they don't have the ability to care for, and individuals are receiving the care and level of support that they need to thrive?
I'm not sure who wants to answer that. I can say that there are people, I'm aware of situations where providers have a very difficult time supporting people, but I think that's a question that's beyond the scope of this task force. I mean, my understanding is this is talking about the exceptional supports process. That is a conversation that was being held in Medicaid's level of care task force, so I don't know if anyone wants to respond to that. But what you're talking about, Amy, is a regulatory requirement that a provider has to make referrals and continue to support someone so they're not left without needed supports until they can find a different provider.
And I would just go on to say, I mean, that is something we've talked about with you and here at the cabinet quite a bit. And if it was a simple answer, we certainly would have resolved it by now. But I can assure you those conversations continue because we recognize that it's a challenge for everybody, and it's certainly a challenge for the people we're trying to serve to be, in the care of someone who feels overwhelmed. So we share, concern about getting resolution, but unfortunately, it's a complicated issue.
Thank you. I appreciate your answers.
Commissioner Morris and Mrs. Johnson, I don't think we have any more questions. We appreciate your testimony today. That calls for the end of our meeting. Our next meeting is on Monday, September 28th at 1 o'clock. September 28th Eastern Time, 1 o'clock Eastern Time, September 28th, and Senator Adams will chair that meeting. We appreciate everybody being here today. If somebody wants to make a motion to adjourn, we'll adjourn. Motion by Senator Parrott, we're adjourned. Thank you, everybody.